My name is Dr. Yvonne Patterson, and I'm an assistant professor at Central Connecticut State University. And I'd like to talk to you about a topic that I've done a lot of research in, and that is with African descent women and HIV/AIDS. So the title of my talk today is an epidemiological and intersectional approach to understanding African descent women's HIV risk. So when we look at African descent women in the United States, they're fourth in terms of all subgroups that are impacted by HIV/AIDS. They represent 61% of all new infections, even though they're only 13% of the female population in the US. They're also 16 times more likely to be diagnosed with AIDS than are European descent women in the US. And they're more likely to die due to complications of AIDS, even though there's been life-altering technology developed where it's not HIV/AIDS is no longer considered a death sentence. So although there's a trend downwards in terms of infection rates, 92% of the time when infection is African descent women contract HIV, it is through heterosexual contact. And I put an infographic over here so that you can actually see how the group is impacted, both men and women. So this is a story that is not only related to African descent women, it is a story of the African descent population in the United States. So when we look at infection rates, even though African descent populations only represent 12% of the population approximately in the US, they have nearly 50% of the infection rates that occur in the US on an annual basis. And so when social scientists have contributed a lot in terms of helping us to understand how the virus or any disease is spread throughout our society. And so the epidemiological framework is used to critically analyze the multi-causal nature or factors that impact the people contracting disease in society. So it's not just merely a problem of heterosexual contamination when we think about HIV/AIDS. It is an interplay between several variables: the vector, the agent, the host, and the environment. And so more recently, researchers have begun to outline the interrelated, overlapping nature of these factors that may be unique to each setting and each population. And so therefore, that is why an intersectional approach also helps us to understand how HIV/AIDS impacts African descent women more so than any other group of women in our society. And I outline these different variables that are related to each part of the epidemiological framework. So I'll go into some of them now in regards to all women in our society. So when we look at the host in terms of the epidemiological model, what we're really talking about in terms of all women is their biological or anatomical vulnerabilities. So women who have the anatomy that is more receptive during sex rather than insertive are more susceptible to contracting any sort of disease. And in this case, we're talking about HIV. So women who are exposed to interpersonal violence are more likely to engage in riskier behavior. This has been information that has been researched time and time again. But what we need to begin including in this idea of violence is structural violence. How structural violence, violence that is perpetuated through government and through the structures of our society, really impacts HIV risk factors for women, African descent women. So the agent is the behavior itself, or the the transmission itself. And so for women, the CDC says that when women contract HIV, all women, they're 85% of the times it is through heterosexual transmission. 15% of the times it's through intravenous drug use. When we look at STIs make it more likely for women to contract HIV because you contract HIV as with any other STI the same way. And it also makes women more vulnerable to contracting disease. When we look at the environment portion of the epidemiological framework, this is where most of the work is being done, or most of our understanding is coming from now in terms of African descent women and the rate at which they are contracting the disease or the virus as opposed to other women. And what we're finding out is that according to the World Health Organization, the social determinants of health have a lot to do with the epidemic and the speed of the epidemic within this subgroup. So the social determinants of health are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of daily life for the individual or for any group. So what we mean by this are economic policies and systems, developmental agendas that exist or don't exist, social norms that are there that are related to specific social identities, right? Social policies and political systems can all impede or facilitate efforts to avoid HIV risk, right? So these can lead to higher community prevalence rates in a very direct way. It can lead to restricted sexual networks, which are tied to the rate at which African descent women are experiencing or contracting HIV. So established harmful social norms are related to African descent women's social identities of race, gender, and social class. If you look over here, the CDC infographic will show us the rate at which African descent women contract HIV/AIDS, new HIV/AIDS diagnosis as opposed to other groups. And so here's where I introduce intersectionality. I just talked about the social identities of race, gender, and social class, and how it really impacts higher rates of the epidemic for African descent women, especially low income African descent women. So intersectionality is an interpretive framework that is used to examine how distinct oppressions can converge and simultaneously operate as a single phenomenon in its impact on the lives of African descent women in the United States. And so when we think about our social identities, it's multifaceted and we're one individual, right? And so we can't separate each one of our identities from itself. It comes in that one package. So this is what we mean by a single phenomenon. And so what I've done now is put all of this information that I've just relayed to you together. If we look at only 3 of these social identities in terms of how it's related to the HIV risk and how it increases risk for African descent women, when you look at class, for example, and you look at the large wealth gap that exists between the races in our society, it leads to limited access and material opportunities for African descent and populations of color in our society. It leads also to this lack of resources, to high concentrations of poverty, right? And it's been proven time and time again that the lack of resources is actually a gateway to the most dangerous outcomes, including HIV/AIDS. Race, which overlaps with these other 2 identities, informs us about past and current discriminatory practices or structural racism that exist in our society in terms of policies. So we look on the war on poverty, which actually impacted the incarceration rates amongst women and men of color in our society, right? If we look at the crime bill, the Clinton crime bill, which also impacted the incarceration rates, it also has connections with the sex ratio imbalance that we find in low income African descent communities. That is, that we have more women that exist in those communities than there are men, eligible men to partner with. And so this imbalance impacts the sexual networks that exist in that community. We also know from the last slide, I told you that the prevalence rates amongst African descent populations in general is high. And so we already have a high prevalence rate in these communities. And then you have a condition where you have a sex ratio imbalance. It means that there's a lopsidedness in the availability and the eligibility of men, heterosexual men that women would partner with in their communities. And let's not forget that there's high rates of de facto segregation, which means that there's limited mobility for women to come out of those communities and partner with any other group of men, heterosexual men. And so there's a confinement of disease that spreads more quickly within those communities. So high incarceration is a particular problem. A restricted sexual network is also a problem in terms of African descent women in those communities. And we can't leave out gender. And all of these three identities overlap. That is to say, we can't call out any of these in terms of its impact. And so gender shapes women's exposure to violence, structural and intimate. And when I say intimate partner violence, I'm talking about individual interpersonal violence, but we can't leave out the violence that's perpetuated by poverty, right? And so here we have the feminization of poverty in our society, which really is about how women are more likely to be low income and low resourced in our society just based on their gender and gender socialization. Well, this impacts women of color more often than it does European descent women in our society, right? And gender also shapes women's limited ideas around sexuality and gender, right? Which limits their power within themselves and in relationships. And let's not forget that male condoms are a male controlled technology. And so all of these things together work together to present situations that would create more risk for this group of women than other women, right? And so when we look at the research, what it tells us is that the number one way that women who are African descent and live in low income communities contract HIV is through multiple and concurrent partnerships, right? And the foundation has been laid because of their social identity and their limited access to resources. So poverty in itself curtails choices, it limits mobility, and it shapes sexual networks. Poverty destabilizes relationships in that there's a sex ratio imbalance and there's high incarceration rates, and it drives housing instability as well, which is also related to HIV risk. So here are some key points. I'm going to wrap up my presentation now in terms of African descent women and HIV/AIDS and intersectionality. The intersection of race, class, gender oppression creates a reservoir of HIV risk for African descent women, which are most favorable for the reproduction of HIV/AIDS. And the implication is that it's not always possible to say with certainty that a woman's gender or a woman's race or a woman's class alone exposes them to HIV risk, but rather it is a combination of oppressive circumstances, which allows the speed of the epidemic within this population. And when we look structurally in terms of intersectionality and structure, is the overlap in structures of domination, which I just went over, that limits women's power and therefore their choices and decision making. Employment, healthcare, livable wages, affordable and quality housing expose them to a unique risk for contracting HIV. So this group is most impacted by the feminization of poverty, which I just mentioned, which would directly link itself to structural racism or structural oppression in our society. Poverty curtails choices, it limits mobility, and it shapes women's sexual networks, which directly is linked to HIV risk. Poverty also destabilizes relationships, which is linked to policies that are created, which mostly impact people who have limited resources in our society and are of color. And representation in terms of intersectionality is also important to explore as well, in terms of how women, African descent women, are represented in popular culture and how that shapes the interactions that they have with professionals who are responsible for helping with prevention, right? So once infected, women grapple with a fourth stigmatization or spoiled identity other than race, class, and gender, and that is disease, right? So women in popular culture who are African descent are associated with being a drug user or a sex worker, and not just a woman who was in a relationship who contracted a disease from a single partner. Thank you.